Right, let's get started. Good morning. Thank you for coming in so early. My name is Edward Rowland. I'm the Medical Director of St Bartholomew's Hospital. At the moment, any talk and any environment, any forum at the moment to junior doctors, consultants, nurses, anybody in the healthcare starts with two things. One is an enormous thank you to all of you for what you're doing at the moment. It's a heartfelt thank you because the second part is the huge stress everybody is under. And it's focused on you, and I'm sure you've seen many of the outpourings of gratitude from the public. And everybody realizes that you, particularly the junior doctors, are at the real forefront of this. It's terribly unsettling times. It's unprecedented times. We really have no idea how long this will last, how bad it will be, and we've got very little on which to go on other than the experience of other countries, a little bit of history, learning from other people's experience. And I think you'll all recognise that everybody from the very, very top downwards is working tirelessly 24 hours a day to try to work out what's best for everybody, both to look after patients and both also very much to look after the staff. You are the vital part of ensuring that we do the best we possibly can, and I think we're all very proud of the National Health Service about what it can deliver. There are problems without question, but being honest about them and recognising them, and everybody sort of raising their hand to say there's a problem, please help fix it. All of these things are being escalated. I'm just going to talk a little bit about the hospital, what's happening to St Bartholomew's Hospital as we speak at the moment, but anything I say now has got a very high chance of being changed, possibly tomorrow, certainly later this week, and most definitely next week. As you realise, we have essentially cancelled virtually all elective work in the hospital. Outpatients has been reduced to absolutely essential, urgent work in outpatients. So the character of the hospital has changed enormously over the last couple of weeks, and hence the work we're doing is changing, and hence what you are being asked to do is changing, and that's going to continue. Because the nature of this hospital, we are a very large, essentially critical care hospital, because of the nature of our work. That is essentially being expanded to provide capacity for the patients that we know are going to end up in respiratory problems as a result of this virus. So everything is being geared up to change it to a very large critical care hospital. We are almost certainly going to have in the next week or two over 200 critical care beds in this hospital. We need the staff to be able to look after that, so the need obviously is for critical care skills, and part of that process is going to be asking people to learn about that, essentially to retrain in double quick time. Our COVID positive area at the moment was just 6A, it's now 6A and 6D, and that will expand. We also are going to be the hub for surgical emergency work, cardiac surgical emergency work, and thoracic emergency work in London. So we will be organising across London that kind of emergency work, and a lot of it will probably happen here at this hospital. So part of our work will be to continue to offer emergency cardiac surgery, emergency thoracic surgery. So that has to be protected. Exactly how that will work, we still are not certain, because it's both here and Harefield Hospital as things stand at the moment. The other area, obviously, of the hospital is going to be looking after people who have the kind of problems that we deal with, cardiac problems acutely, cancer problems acutely, perhaps one or two cases of endocrine emergencies. There's obviously a big respiratory cystic fibrosis service this hospital runs, and there will be those with or without the coronavirus element to it. So there will be some core services, but they're very small, very limited emergency stuff. So the vast majority of the work that's going to go on here is going to be related to coronavirus patients requiring critical care or step down or not yet requiring critical care. And that work is going to be developed this week. So things are going to change, so you're going to be asked if you can fit into that kind of program. We're going to talk a little bit later about how that might work. Mary White, who's in charge of training for critical care, is going to come down in a moment. We have Jonathan Lambourne, who is our lead infectious diseases consultant, who I know will be very happy to talk to you about personal protective equipment and how we keep you safe. There are obviously many other questions, so I don't want to stand here and just spout to you. I want to hear back from you, your worries, your concerns. I'm just going to ask Mark Westwood to say something about the training and other aspects of what has had to change over the next weeks. How long this is going to go on for, we clearly don't know. But thank you again for all you're doing. And we are here to respond to any kind of issues you have. I put down a whole lot of topics that I thought would come up this morning. They included food, car parking, travel. I didn't think about the awful business that I read this morning on your WhatsApp about people being attacked for their cards and security, and we ought to address that. So again, a heartfelt thanks from me for all you're doing. Mark.
Yes, good morning everybody. I think many of you know me. I'm the Director of Medical Education, but I'm in charge of your training and also your pastoral care and welfare. And really from me, just the same, an enormous thank you. The way in which you have embraced these incredibly challenging times within the NHS and within our site has really, quite honestly, just dumbfounded me. You have utterly impressed me. The number of people in this room who have contributed, either individually or as groups, I have never seen so many rotas written, rewritten, and completely redesigned in the space of 7 days. It truly is a testament to your dynamism and your professionalism in a time of uncertainty and a time of difficulty. So I'd just like to say thank you very, very much for all of that. What I'd also like to talk to you about very briefly is your training. Now, it keeps changing, and I think it is a little bit confusing, and many of you are very, very worried about what's going to happen. But let me put this very simply for you. In reality, I think as of the end of about a week and a half ago, your training was essentially paused. For many of you in the specialties and the areas in which you wish to train, it is now virtually impossible to do that because of the nature of what we're doing, and also that we're asking you to do things you've not done before at breakneck speed. When we get through this, which we all will, we will then work out where everybody is, and training will restart. But essentially, for the present time, Your training has just simply been paused, and we will unpause it when we're able to do so. What I and the entire team here at St Bartholomew's Hospital and outside in the wider trust and beyond will guarantee is that none of you will be adversely affected by any of this in terms of your training. So if you want to not have to worry about one thing, it really is your training, because we will pick it up, we will sort it out, and we will deliver it for you. That said, I just want to say thank you once again for all your help and drive to really deliver a hospital that's doing something very, very different even as we speak, and will continue to do so. And I'll hand back to Edward, who I think is now going to take over with the Q&A session.
Right. Hands up. What's first on the list? Would you like Jonathan to talk about personal protective equipment? Yes, I think that's probably reasonably top of the list. So, Jonathan, can I ask you? Jonathan has been an absolute star here. He's a real expert in virology, bacteriology, everything, and so vital. And Jonathan has been working round the clock to sort of give us advice, the latest updates, and help, and probably be more important than anybody else in sort of protecting us. Jonathan.
Brilliant. So I must say that PPE has definitely been the number one FAQ since this has begun. And I guess what I would say is that things have changed since the outbreak began. And so with that change, I think things have been quite unsettling. So in terms of when things were first realised, there was one set of PPE that was advised, and then we've changed, and Public Health England have changed the PPE that's been advised. And I think there's a real perception that I think is understandable that is driven by resource limitation as opposed to science or understanding of the infection. So I think it's just helpful to kind of run through things a little bit. When the infection was first realised, it was classed as a high consequence infectious disease, meaning it was a novel infection that we hadn't seen before and didn't know how it was transmitted, what the case fatality was, what the secondary infection rate was, and so on. And now we have much more of that information. As of the weekend, Public Health England and WHO have stepped down this organism as a high consequence infectious disease. So it now no longer is deemed a high consequence infectious disease. So I think that's an important thing to say. The other thing to say is, as a trust, we are following guidance from WHO and following guidance from Public Health England. So we're not making this up ourselves. We're taking advice from experts in terms of PPE. And so in terms of the change in recommendations of PPE from initially wearing aerosol protection in terms of FFP3 fitted masks and gowns and visors and things, down to wearing an apron and a surgical mask and gloves, that is not resource dependent. That is because of a better understanding of the infection being droplet transmitted as opposed to primarily aerosol transmitted. So that change in PPE is driven by our understanding of the organism, not by resource. The second biggest question is about the importance of fit testing versus fit checking. So in those situations where you end up requiring to do aerosol generating procedures, of which the list is reasonably short, the recommendation from both PHE and from WHO is to wear an FFP3 mask. And there is debate and uncertainty about fit checking and fit testing. Fit testing is something that you do once with one type of mask to see if that type of mask fits you. That means when you go forward, you then know that mask fits your face and you can use that mask kind of going forward. The issue is that we've had different supplies of FFP3 masks kind of coming through, and so you fitted with one mask doesn't mean you necessarily fit another mask. And doing a fit test for PPE means that mask then has to be thrown in the bin. And so the move from fit testing to fit checking in terms of emphasis is resource related, in terms of there are not enough FFP3 masks to go around for everyone to be fit tested who needs to be. Now, going back to this does not mean that wearing a fit test mask that hasn't been fit tested is useless and doesn't work. the key thing is the fit checking, and fit checking is something you should do every time that you put on PPE. It's the process of donning. It's when you put on everything else, you put on the mask and you do your fit checking at the same time. That's been shown to be protective and beneficial, whereas there's interesting kind of data and studies suggesting that fit testing undertaken has no impact on acquisition of infection or outcome. And so fit checking is the thing that you should be doing as part of your PPE donning and doffing training, because it will change with masks. We'll get different batch of masks in this week, we'll have a different batch of masks in next week, and so the key is each time you put on PPE, then it should be fit checked. And the key thing is as well, it is only for those situations where you're in the face of kind of aerosol generating procedures, and the list of those is reasonably short. So it's intubation, extubation, non-invasive ventilation, high flow oxygen, and in the CF cohort, it can be induced sputum. And bronchoscopy, yeah, exactly. And it's interesting, having looked in this quite a lot of detail, there's some really good references out there in terms of what constitutes an aerosol generating procedure, why they're deemed aerosol generating procedures, and actually the data is reasonably limited. The data for AGPs, so aerosol generating procedures, is really strongest for intubation. The data for other things is far less robust, and so it's about kind of risk benefit. And so I would say we're sticking to the guidelines of PHE. There are some really nice posters in terms of what to do and how to do it. And we think we've now got a better understanding of the organism than we did even 2 or 3 weeks ago, especially from stuff coming out of Hong Kong and Singapore. And I think the thing to say is that it's likely that many people in this room will probably get COVID. That's a fact of life. But that if you look, I will try and circulate earlier, but some really interesting data in terms of your risk of severe infection requiring hospitalisation, and then risk of severe outcome requiring ITU, and so on. And in terms of looking at the people in the room, the risk of any of those outcomes in terms of severe infection or requiring any form of hospitalisation is kind of less than 1%. And so I would bear that in mind in terms of for healthcare workers, then it's likely that infection will happen, and when that infection is acquired is impossible to tell. People will always attribute infection to occurring in the healthcare setting, but equally, given the incubation was 2 weeks ago, imagine what you've done over the last 2 weeks that may end up, the sort of exposure you may have had over the last 2 weeks that may be the initiating event. So I just think, let's think about, a bit pragmatically about this, and let's kind of do the best we can with the resources that we have. So for most people, it is droplet PPE, which is surgical face mask, apron and gloves. For aerosol generating procedures, it is FFP3 mask, eye protection, long sleeve gown and gloves. And happy to take any questions.
I suppose I would add, a high index of suspicion.
Yep.
For anybody you come into contact with, so questioning carefully, and wearing the protection for if you have any concerns, wearing the surgical masks and gowns and gloves. And then finally, like me, ending up with raw hands. I've never had such raw hands in all my life. Every moment I'm just washing with soap and water. And whatever that stuff is you put on to try and make, was it fairy liquid or something? Yeah. Right, question?
Given our relatively high rate of getting COVID, is there any justification for where is surgical face masks that you're just seeing vulnerable patients in clinics or on the routine wards?
So the question for those who didn't hear was about should we just be wearing face masks all the time, essentially. So that comes down to what we think is the rate of asymptomatic infection, I guess, in terms of what's the rate of people having and shedding the virus with no symptoms. So the key is, as Edward said, that the key index is low index of suspicion, and what we're hoping to do is anyone who's coming to clinic is triaged at the front door, and anyone with symptoms is diverted to a specific clinic. So Clinic 2 we've now set up into a COVID assessment clinic. So in terms of folk who come and see you in clinic should already have been triaged at the front door. And so the rate of carriage or the rate of infection in people who are asymptomatic in studies from both Germany and in Singapore is about less than 2%. So about 1.5% of people you'll be able to detect coronavirus in their kind of secretions, I guess, when they don't have any symptoms. So that's the question. Okay. Oh, in terms of staff, that's a good question. So I think it works likewise in terms of if again, 2%, less than 2% of staff will therefore have coronavirus in their nose, but not be able and not be aware of it in terms of any symptoms. And I guess I would say, thinking about how it's transmitted, if you're sitting in clinic and you're breathing, you're not likely to be generating any aerosols or droplets and things. So the issue is in terms of, yes, we can detect it, but what's the transmissibility of that individual who isn't coughing or sneezing and things? Because it is droplet sort of stuff. If you have a cough or sneeze, then clearly, yes, it will kind of transmit. But I don't think at this stage that there is sufficient evidence of widespread asymptomatic carriage to justify wearing a surgical face mask for all interactions. And I guess this also comes down to, it's a science question, but it's also a resource question as well. So in terms of if we were to do that, then we would, again, quickly run out of surgical face masks.
I think quite a few of the anaesthetic colleagues sort of were a bit unsure as to the risk of transmission in asymptomatic patients that you're intubating. Is that the same as the asymptomatic patient that you see in clinic? I know that's a really difficult question.
Yeah, no, it's a difficult question. I mean, you're by definition going to have exposure to droplets and aerosols by virtue of the procedures that you're doing. Again, it's the same risk applies in terms of it's going to be 2% of the population or less will have asymptomatic kind of carriage. There's debates going on in terms of the surgical side of things, in terms of the elective admissions, whether they arrive and they're swabbed, and if they're swabbed and found negative, then they proceed to surgery or not. It's something we're working on, which would then mean that you know the person who's coming in has a negative swab, so then no symptoms, negative swab. You've got 2 negatives, which suggests the risk is much, much lower. Again, I would argue that wearing a surgical face mask for that gives you quite a bit of protection. It may not be as complete as kind of for aerosol things, but I would argue that a surgical face mask in that situation is adequate, is okay. The other thing we're thinking about doing is in terms of addressing the risk of those where we don't know. So say if there's an immediate transfer required and needs urgent surgery where we don't know, then the algorithm as we work it currently assumes COVID until proven otherwise, which means PPE for intubation. It's a good question.
An important point, I think that very important point, assumes is. George?
Can I ask about the situation in cardiothoracic surgery of patients with chest drains and particularly air leaks in chest drains? Does that become aerosol generating?
No, I don't think. I'll ask. I'll check. But my understanding is that it doesn't. But it's a good question, and I will check just to see. So presumably, the risk is kind of.
So if you have an air leak, you've got a hole in your lung coming out into a chest drain into the room. Yeah.
And in terms of, excuse my ignorance, but in terms of anatomically, does that not go through an underwater
seal? Yeah. Fine.
Okay. So that I think would be an important bit as well, and it's often deemed the pressure with which stuff is expelled. So in terms of it's either being kind of face in when you're intubating someone, or it's things like high flow oxygen when you're blasting kind of 60 litres a minute. Whereas I think normal respiration through a leak would be the same as normal respiration through a mouth. But I will check. That's a really good question.
You're actually performing the surgery with a visitor cells if there's a leak in the lung during the surgical procedure.
Yeah, no, true. So I think I've talked a bit to Kelvin Lau about that, and in terms of the main thing is it's deemed that when you're doing most of your thoracic surgery, my understanding is the lung then collapses. You use a double lumen tube, the lung's then collapsed, and actually that lung is then isolated, and there's no leak from there. But you're right in terms of when there is a situation of a leak. I'll have a chat with Kelvin and we'll see. But thank you.
Yeah, a question about doctors being off sick, because I think we're going to have quite a lot, probably more than normal, and I don't know what the thinking is about how fluid we are about going back and forth, because we want to make that as efficient as possible. Doctors having to call in sick at short notice, come in again well-ish at short notice, and one, like, how maybe we can put them to use at home, because speaking to some of my friends, they're kind of annoyed sitting at home feeling like they're useless, and 2, about maybe a single point of contact or something for doctors who are going back and forth, because I know we've got different rotas and different people coming back and forth, and we're COVID or not COVID at the moment, so maybe we need a single point of contact, something like that.
Yeah. No, good question. The question for those who didn't hear was about how to manage the fluidity of staff going off sick and coming back and going off sick. I think there is. I would speak more about it, but I think there's a big piece of work about staffing. From my point of view, there's a big question about staff. Testing is another FAQ that I get asked about. I think we just need to be careful about. It would be great. If I was unwell, I would want to know. For several reasons. One, it's just nice to know, and two, it means that when I recover, I know I've had it, and that's a very valuable bit of information. The question comes down to the sensitivity of the test in terms of, does a negative test mean that you don't have it or didn't have it? I think what I would be more interested in looking at is in a month or two's time, when serology testing kind of comes out, knowing that did I have it? That was my flu-like illness I had 2 months ago. That was COVID. That I think will be more reliable than the nasal swabs and things. But in terms of staff fluidity, there is a big piece of work going on, I think, about staffing through Rocky Health.
I think there are a number of questions there. One is isolation, self-isolation and the rules. Are you all clear about time? Yeah. Secondly, staff, it's important that if you do isolate or you have symptoms, that you contact your manager to tell them, and early you can do that in the day, the better. The staff testing, we are escalating daily the requirement for this. It is a capacity issue because there just isn't enough testing available. Patients, unfortunately, are a higher priority, so we need to know, both for them and also for you, do we have it? The capacity is being increased. I anticipate that a week today, we will have the capacity to test staff. That's what I'm being told at the moment. I believe that there will be some testing this week at a low level, but they have already increased 10 times the amount of testing they're able to do here. And as Jonathan said, I think we're all waiting for the antibody, and my understanding as of this morning is that it's a matter of a few weeks away. Then there'll be so much, I think we'll all be so much happier to know that we have had it or haven't had it, and we can conclude from that some important things about our own safety.
Dr. Rowland, just to while everyone's here, many people would have heard about this, but just if you are calling in sick, as well as telling their team, to make sure that the site manager's been informed as well, so that there's an awareness of overall sickness in the hospital.
Sorry.
I just wanted to ask, this is not a PPE question, I don't want to sound alarming, but
Sure.
I saw in the news over the weekend there were 3 30-year-old doctors in Norfolk Park committed twice with coronavirus and 2 ENT consultants up north. And I was wondering, is there any evidence of an exposure or viral dose-related extent of the severity of the disease?
So it's a good question. One, I would urge some caution. There was stuff in the press about us having to consultants on ECMO here, which was not true. So I appreciate there is concern, but there is also a degree of fake news around. But I won't question that. But just so I think there is some degree of exposure, and it comes down to some of the virology of it, and it comes down to the droplets versus aerosols. So droplets are large. They fall to the ground quite quickly. They get deposited in your upper airways. They do not travel down into the alveoli. And the theory is that where the infection lands, the infection begins. I guess the concern is more about aerosols. So if you've got small aerosol kind of particles, then they can end up traveling down into the alveoli, and that's when the infection can develop kind of with a pneumonitis rather than an upper respiratory tract infection. And so what I would say, this comes down to the idea of being aware of what are the aerosol generating procedures and protecting yourself during those times. So ENT, whether they're in tracheostomies and things, again, that's an aerosol generating thing, and ITU folk as well. So likewise, they'll likely be in situations where there was optoflow. And it'll be interesting to know whether this was impossible to know when the infection was acquired, and tracking back in terms of, was this before we knew much about COVID and exposures were happening, before we were screening patients? Because it's only been in the last couple of weeks that we've moved away from contacts and geography to base our screening to just thinking about everybody. So I wonder whether, if those individuals did unfortunately acquire the infection, it was in the setting prior to us having a heightened cough in order to transmit. So I would, while we work things out, I would have a reasonably low threshold for saying, okay, I've got a cough or I've got a nasty kind of runny nose. Then there's always going to be a grade in terms of does one sniffle or does one cough mean I stay off work? It's going to be impossible to kind of completely kind of dictate that, and I would base it on kind of clinical judgment. If you kind of go, actually, I feel unwell, I don't feel great, this is different to how I normally feel, this is unusual for me, then I would use that as justification to say to stay away.
Stay away. I think that's a very sensible piece of advice. If you're in doubt, stay away. Things will become apparent in a day or two. Clarity in a day or two. Yep. You happy with that?
Yep. And if say a day or two later nothing's changed, it's not got any worse, we're not developing a cough, can we then come into work, or once we make that call cautiously, do we then have to stay away for 7 days?
So I think this is where testing will be quite handy. I think where you kind of go, what was it? Because if you then go, symptoms resolved, test negative, tick, I can return to work. Whereas you're left in the situation of going, I feel better at day 2, but wasn't it? Could I still be secreting? So it's tricky.
It's exactly the point we're making, and I hope literally by a week's time we will have the ability to do that for you. Make life so much better for us all.
But I think for now we're saying that if you've gone off work, then it's a 7-day time away.
Any more PPE questions? If not, can I introduce Mary White, who's in charge of retraining 5,000 doctors, at least, I think. Mary, come on. Mary is head of the program to help us with the training of essentially doctors to help in critical care. Mary.
Thank you. Good morning. You're very welcome, and thank you for all the help and all the enthusiasm you've shown so far. One of the things that we're going to need to do is train up a lot of people who are a non-ICU, non-anaesthesia background to be able to manage patients in the intensive care unit. And the structure of the programme is going to be, by the end of this week, and certainly no later than the start of next week, you will have an online e-learning forum that you can actually tap into and use. That should give you some basic introductory information. There will be workshops that will be running up on the 6th floor, probably 6C or 6D, away from 6A at the moment, because that's quite COVID positive. The workshops, Lynne and Andrew have got lists of names of people, so if you're coming, let Lynne and Andrew know and they will allocate you a time to come. We'll keep the workshops quite small groups, 8 people only. They're 3 hours in total, and then for the first group of people who are coming up on Tuesday morning, your next step of training is going to be embedded with the ICU team. So you've got a buddy system, and then we'll roll it out according to how many people we need to train up. We foresee at the moment that while we're in 6A, we will just have a small group of people trained up, but I think that will change very rapidly over the next day or so. The capacity will be to train up 16 people per day, and then the idea being is that once you're trained, you embed with the ICU team, you won't be independently working on the unit by yourselves. You won't be expected to prone people or intubate people or do any of the advanced ICU care. You will always have a support system around you. Any questions about that so far? No?
So my question is, we've had, from oncology, we've had quite a lot of, you may be doing this, you may be doing that, you may be going here. Do you know when there'll be a better idea about where and what?
Yeah, I think that's part of the problem, is the lack of knowing how soon everybody's going to be deployed. I think at the moment, the footprint is just within 6A, and at the moment there are enough cardiology trainees that are lined up to be trained up. So it definitely won't be over this week, but it may be thereafter. I think what we do need to be prepared for is that things will change, and things will change rapidly. You won't suddenly get a phone call, you must go here with no training and no support system, okay? That will all be around you before you actually have to deploy.
I mean, just to say that's part of the reason that we've got this all set up already. So we anticipate a substantial increase in the number of ventilated COVID positive patients here ultimately. That probably is not that far away, but at the moment we have a bit of time and we're going to use that time as productively as we can to train you all up so that exactly what you just described, which is you suddenly get told you've got to go to ITU, absolutely does not happen. That's not fair, that's inappropriate, and it's not great for patient care either. So that's what we're doing at the moment. That's why we've got this programme. And we're looking really to get probably 70, 80, 90 of you through that programme in terms of junior doctor workforce on the site. So the numbers are huge, but we've developed a programme and we believe that we can do it. We appreciate its breakneck speed, but at the moment everything has to be like that.
There's been a lot of work over the weekend to look at what we need to deliver, trying to think about where's the need, how are things changing. There is a need to provide more support to Whips Cross and Newham because they're at the moment much at the front end. We are the sort of second phase in this, and you will find the patients on the wards today very different than what you had last week. And we're working through a whole number of plans to redistribute, redeploy staff. But as Mark said, it has to be in an organised and a way that doesn't put you in situations where you're feeling, I don't know what to do, I've just no idea.
The other thing I'd say is that we've got lots of communication channels through all the various WhatsApp groups, but I am actually on most of them. So I am keeping my eye out, as is Edward, as are all of us who are sort of more senior leaders within the team at the hospital as to what's going on. So if we do see that people are feeling uncomfortable, we are absolutely taking that on board, and we're keeping a very close eye on things, that we will just adapt and things. To some extent that will be adaptation as we go along, but I certainly don't want anybody to think we're not listening. I certainly don't want anyone to think that we're not paying attention, because we are. We're constantly looking at this. Most of my day is watching what's going on these groups, getting emails, listening to feedback, looking at the situation, discussing with everybody else and working out how we do all of this whilst being safe and being appreciative and all the rest of it. Okay.
Sorry, Dr. White, you might not know the answer to this, but in terms of the first floor versus the sixth floor IT anaesthetic doctors, are we becoming more cohesive, or are we going to look up the cardiac and you guys do?
Yeah, I think the initial plan is that, so we've pulled the general ICU trainees from the first floor to the sixth, so there are spaces on the first floor, and the initial plan is that because there is emergency cardiac surgery still going on, is that the first floor units will need to be staffed and managed by anaesthesia, and some of our surgical colleagues are going to step in as well. I would imagine that will change and evolve as things evolve. We will need some people from the first floor to come and support the rota up on the 6th, because we will extend into 6C and into 6D. So Liz Ogilvie is on board with that. That will happen. It will just, how soon it happens will just depend on how rapidly we're going to be ramping up.
You said that everyone in our groups may need to be deployed within this hospital. Should we be expecting to be deployed outside the hospital, or are we expecting to bring people into this hospital to help us?
At the junior level, and Mark, I mean, as things stand at the moment, we don't see really almost any of the junior doctors being deployed elsewhere. Kerry, as far as cardiology is concerned,
I think
to reiterate the point about the services that need to continue, obviously the cardiac surgery operating as pan-London emergency level, that will need to continue. Some of the cardiology, acute heart attacks and arrhythmia service. So that will need to continue, and our anticipation is the need for the expanded ventilator population will take up nearly all of our junior staff here.
Yeah. I mean, I did so just to reassure you further, I actually had a call with one of our senior managers on site, and we went through all the numbers and did all the calculations, and it's exactly that, the demand for ITU and for our junior medical staff to support the ever-expanding ITU, as we probably expand quite rapidly into a very large ITU, consumes almost the entire junior doctor workforce. The remainder of the junior doctor workforce we have on this site is going to be needed to keep those small services going, so the basic cardiothoracic surgery, the very acute cardiology, the bit of oncology, etc., etc. So I don't, as it stands at the moment, envisage people, certainly at junior doctor level, being requested to go off site.
I think the other thing just to bear in mind is that as the units open up, there will be a skill mix across the unit, so it won't be a completely ICU naive team looking after these patients. There will be, certainly the consultants' rota has changed. We're going to be doing 12-hour shifts, so you'll have a consultant on the floor day and night. As this progresses, then that may change because we will be getting sick or we'll be retrieving, or but as we're rolling this out, there will be a skill mix of both ICU nurses, therapists, junior doctors and consultants, all with ICU experience that you will be integrating with.
Sorry, if you need to shut up.
Is there still sort of repurposing? Registrars being moved to IT and upskilling?
The question is repurposing of consultants.
Yeah.
Is that right?
Yeah.
Yes. What does repurposing mean? Do you mean they're going to be
So we have had quite a few of the cardiology consultants offering to come and help in ICU, and there's quite a few consultants who've already had some critical care experience. So yes, there will be consultant cardiologists, consultant respiratory physicians running a ward round an ICU, with possibly an ICU senior registrar or a backup of an ICU consultant as well.
So that there will be some changes, absolutely, to deliver care at the network hospitals, to deliver care here on a sort of different rotational basis, working in teams to look after the non-ventilated cases. So yes, there will inevitably be changes in the way in which we work. Yeah. Right. Other questions? Lynn, I'm going to rely upon you reminding me of all the things that we talked yesterday. Congestion charging has been suspended. There are car parking places in the rotunda. There is free car parking in NCP for NHS staff, and somebody accessed it yesterday, found it very straightforward. Food. We are organising food for areas where there are COVID positive patients. So we're just working yesterday on how we get food into that area so they don't have to keep coming in and out for staff. Maggie's Centre. I'm working on trying to get the Maggie's Centre available to us as a rest area. I don't know if you know where Maggie's is. Look at the Great Hall. To the right, there's a new building which created an awful lot of antagonism by architectural people. That is a wonderful little space, and I'm trying to get that for some rest space for people.
Do you want me to?
Sorry, this is healthcare.
Yeah.
There is a form which we've sent round. Have you all filled it in about your skills and your health issues? Please, if you haven't, please do it. Have you got it? It was sent round. We will have to send it round again. You don't have it. Lynn, you'll send that round again. Please do that today. Please, please, please do it today. Need to know, what skills do you have above and beyond being wonderful? Secondly, what health issues do you have? Because there are going to be people who have health issues we must not put in certain areas. Pregnancy is one of them, moves 50% of the people here. But there are obviously pulmonary issues, other medical issues that we must know about, because we need to try and work out distribution and where to ask people to go. But if you have healthcare issues, we will take that and recognise that that should keep you protected from a higher level of exposure to coronavirus. Right, pay.
Okay, so for pay, this is basically changing so rapidly, and in reality we're making rotas, as I said, almost every other day. So it's impossible for us to genuinely know what each of you are actually doing in terms of your hours and shifts work, whilst we change so radically what we're doing. And as I've said to you, many of you will be working in a completely different environment within 2 weeks. My suggestion to all of you is the following. We will, of course, pay everybody appropriately. That's just a given. There's just no other way to do this. However, what I suggest is that you do the following, is that you keep documented the hours and the shifts that you're doing, because whilst we write all of these rotas, what will be almost impossible for us to keep track of is who individually has done what. So if you as an individual keep all of that, so we have all of that and it's documented, then we will sort out the money appropriately afterwards. So there will be a catch-up phase with exactly what you've all worked. I can't honestly see any other way to get this to work for you. That does rely on a bit of trust and probity, but probity is the basic tenet of medicine. It doesn't work. So I'm very happy to go with that. So you just document, you keep those documents, and then when we've got a bit of breathing space and the rotas have settled down, during this interim phase where everyone was shifting around, we will just work out what everyone was owed and what everybody genuinely worked. That's my proposal. As I say, you can give me another one, you can email me directly. I can't physically see how it would work.
So ideas, please let us know. In terms of communication, so important, could you all make sure you are on SBH Doctors?
Yeah, so anyone who's not, that's the email trail. I sent out some information about that. It's Mashida Khan, who is the person who's really done that. So if you haven't received that immediately in that email, you can comment through to at the end. Just so that you're getting all the emails that we send out.
So if you have not received anything, because you should have done, from SBH Doctors, the email address, please let Mashuda or Lynn or me or Mark know, and we will make sure your name is added to that.
And just to pass that on to your teams as well.
And that it's so important that we all pass on these pieces of information to our colleagues, people who aren't here this morning. One other thing is accommodation. So we've arranged rooms in local hotels here. Again, Ronki stayed there, is organised to stay there for
at least 2 weeks.
For at least 2 weeks. So if you've got people at home who you're worried about have an infection and you don't want to go home, or not other reasons, so if you need, let us know and we can sort out accommodation for you.
Just to say this, the system on WeShare did work pretty well, but if it doesn't, just there shouldn't be too many of you, and I'm happy to facilitate that for people. So anybody who's struggling or can't find the forms or anything about accommodation, just WhatsApp me or email me directly and I'll help you through it all, okay? Because it can be sorted. It was sorted pretty quickly on Friday, so I'm confident it does work very well.
Jonathan.
It was just a very quick thing about communications is we'll end up getting patients coming to clinic who have been triaged as having symptoms, and one of the key things we need to do is identify the teams who are looking after those patients. We've got a list of numbers, but what I would urge you is that if you have the induction app, can you please check to see that the details that are relevant to your specialty in your area are correct, and if they're not, then correct them would be great. Thank you.
Do you want to just maybe, should we just touch on that perhaps? I can speak if you want. So just so that people are aware, I think I've tried to filter this down as much as possible, but so that there'll be a limited number of outpatients that will be coming. However, there will be some attending for radiotherapy, for possible chemotherapy, and there'll be a triage system where the receptionist will assess them for symptoms, and if they have those symptoms, they're taken straight away to Clinic 2, regardless of the specialty of which they're under. That will be staffed every day by a different doctor, who will sole role that day will be to assess those patients and to decide whether they are okay to continue on what their plan was, whether they are just sent straight home, or whether they need admission. So that person will have to liaise with the parent specialty just to sort of make a future plan. And I think that will come through. So that means, for example, cardiology SHO will assess the patient, and their oncology patient, they will call the oncology on-call person, which we will designate a specific person for that. And then so that future plans get made. For example, they go home today, but they come back in 2 weeks to have further chemotherapy. So just some of you might be put into that role, just to be aware. And yeah, if there's any questions regarding that, I'm happy to take any.
Okay. Thanks so much. Any more questions? Anything? Yeah.
You said about congestion control. Is that admission as well?
It is. That's my information. Right. Anything else burning interest? I think, okay, let's wrap up. I think firstly, I just wanted to thank Lynne. Lynne has been a complete and utter star representing you in the last week. I know how hard she's worked. So Lynne, thank you very, very much. That's really fantastic what you've done. Secondly, thank all of you. You are the present and the future. That's why I'm interested, because as I get older, I need very good doctors like you to look after me. So thank you so much for all you're doing at the moment. We are here for you. So any problems, any questions, anything you're worried about, please let me know, let Mark know, let Lynne know. Just get in touch with us any time of day, and I mean that. And any questions, any suggestions you have about what we can do to do things better, we need to know. Take care of yourselves. We will win this. There is a brighter day at some point in the future. Thank you very much for all your help.
Thank you.